Welcome to GP Insights with Dr. Ramya Raman. This is a podcast where we unpack the issues that are shaping general practice, from advocacy to health policy to funding reform, workforce pressures, and the respect for our profession that our profession deserves. With each episode, I'm speaking with leaders across healthcare, policy, practice to explore what is changing, what matters, and how can we strengthen general practice for our patients, our communities, and the future of our profession. Today, I'm recording from Perth in Western Australia on the lands of Whadjuk people of the Noongar Nation. I acknowledge the traditional custodians of the lands on which we are all listening and joining from across Australia. I pay my respects to elders past and present and recognise the continuing connection to Aboriginal and Torres Strait Islander people to land, water, culture and community. I welcome all Aboriginal and Torres Strait Islander colleagues who are joining in today. Today's topic is GP-led teams, what reforms that we must get right. General practice already works in teams. We know that. The problem is that the funding system often does not support that team very well, the complexity and the leadership to make that work on a sustainable way. It's an absolute pleasure for me to welcome Dr. Aaron Chambers. Dr. Aaron Chambers is a GP and a practice owner. He and his wife, Alison is a midwife and a paediatric nurse, founded the Grow Life Medical, which was awarded RACGP Australian General Practice of the Year in 2024, due to their innovative, multidisciplinary team approach to general practice. He's also co-founded of Allergy First, a national network of GP-led allergy clinics, improving access to allergy across the country. So without further ado, Aaron, I'm going to hop over to you. Can you start by telling us a little about yourself, the practice, your community, and the kind of patients that you care for?
Yeah, thanks, Ramya. I'm glad to be here. So Grow Life Medical started out as just a little idea that we thought, well, wouldn't it be great if when parents are pregnant and have a new baby on the way, basically learning from our own experience as a parent, what if we could make sure that they've got that tribe or that village to grow up in that's based around the general practice? And from day one, we wrote on the front door and we said, we put patient, family, community on the front door with the intent that, as a GP, you'll totally understand that you can look after the individual in front of you, and there's so many things you can offer, but so many of the problems that patients come with have their origins outside the clinic walls, in their family context, their socioeconomics, the community and the connection that they have to that community. And that philosophy, we sort of intentionally designed a patient journey that's lifelong, but it's rooted in that connection in early life, and rooted in connection of a team working across a single patient database. And it's been very successful. We've rolled out, we've now got 5 clinics operating and continuing to grow. And I guess it all revolves around improving healthcare through connection, which I think is our job as GPs, is to really create that connection and understand the health needs of our own community.
That's wonderful, Aaron. And firstly, congratulations. It is so exciting to hear this from a colleague. And more importantly, I think you've just touched on a really important point about continuity, the connection that we have as GPs within our community. We feel it, but the reality is I'm not quite sure that the government and people around us in terms of the structures are really hearing and seeing that. And that's what this is about, to talk about that a little bit more. So can you unpack for us a little bit more in detail about what multidisciplinary care looks like in real general practice? And if you can reflect a little bit about how you have set that up in your clinic.
Yeah. So I guess from day one, we started thinking about, well, what are the needs of our local community and how do we create that connection? And that's really why we started in early life, in pregnancy, in postnatal care, because that's the point in time where individuals are prepared to change habits. They want to create a relationship with a new clinic. They're often looking for a GP after not having had one for many years. And so that's where it started for us. Other communities might have different starting points, but I think that's a very common theme that runs throughout the system. And then it starts to be that, well, how do you mould the clinic based on the needs of that community? And that's a little bit of an organic process. I think it involves a lot of experimentation. And for us, psychology is such a needed service. Mental health, it's now one of the most common reasons for presentation in general practice. So embedding psychologists in the practice. We found there's high demand for dietitians in terms of good advice for kids in particular, and certainly then people with diabetes needing that as well. And it's been adaptive and thinking about, well, what are the high demand areas where we often need to refer externally, and how can we make them part of the practice team? And that has adapted over time. And I think it's part of the reason I believe very strongly in effectively a market-based mechanism for this, because demand changes depending on where you are in the country, and the mix of skills that you need also change. And I think naturally when patient demand is high, those services are successful. And where patient demand isn't there, they're unsuccessful. And that helps adapt your practice environment over time that's highly responsive to what your patients need. And I think that is the most important thing we can think about, is design a clinic system that clinicians can be accidentally successful, is the way I put it. And that's about the mix of skills, intentionally designing the patient journey, making sure those services interlock, make sure everyone's working off one database, and make sure that that matches patient need. And I guess there's one other element there that we'll probably touch on later, but that's leadership. And we've thought very carefully about making sure we've got not only clinical leadership from GPs, but also clinical leadership from allied health specialties.
100%. I think you've touched on the importance of interoperability in that the single database and ensuring that the patient journey is being tracked. Are you able to give us an example of a patient where that team-based care has made a difference using some of the allied health colleagues and their expertise within your team, as well as medical and nursing, and of course the reception and front desk team?
Enormously. I think probably there's two ways I think about that. One is zooming out and thinking of your practice population as a whole. And so at Grow Life, in terms of the clinical governance model, we have a clinical advisory group that's multidisciplinary, consisting of GPs, nurses, admin, a practice pharmacist, and a practice dietitian. And we take that sort of helicopter view of the population health needs of our community, and we come together and share ideas and use that as a reference point for if there are any clinical incidents, how could we do better? What's our data in terms of health outcomes doing? How could we improve that? And I think that mix of skills is really important. I know personally, I feel like I can't possibly do and know everything about medicine. And having those different ways of thinking, I think, create really valuable opportunities for creativity in your practice environment. But then zooming down into the individual, once you've got all these people working under the same roof, they're closely in the same community of practice, even if they're not necessarily part of the same practice team, if they work closely together, you can really change the trajectory for an individual. And I can think of one patient, he's one of my favourite patients, been a patient of mine for many years. Unfortunately, due to some life circumstances, has a long-term history of very poorly controlled diabetes, and has already had an amputation of one digit on his foot, but was facing another with a very serious foot ulcer. But between having a diabetes educator in our practice team who finally managed to connect and help him understand what he needs to do differently about his insulin management and dietary habits, our dietitian as well got involved, podiatrist, all under the one roof. And we were constantly both chatting internally in the practice software, but also when you bump into a colleague in the tea room, you can kind of say, "Hey, how's so and so going?" And I think it's all those things that added together that we actually resulted in that diabetic foot ulcer healing and not resulting in another amputation. But there are many other examples. Families who've come in where they might be really struggling with an infant who's struggling to grow, or some complex developmental pediatrics, where they can be seeing the same speech pathologist, GP, a practice nurse, a midwife, all under the same roof and handing over care. And I've seen the way that, say, for example, our parents groups that we run free for our community have provided such amazing support outside the clinic walls that then results in, I'm sure, a reduction in sort of postnatal depression and better mental health outcomes, because people or humans need connection, and it's enabling that connection and making sure that those patients feel part of an environment where they are genuinely cared for that is where general practice has its most relevance.
And well said, Aaron. Some excellent examples there as well. Now, expanding a little bit further on that, now you and I and most of our listeners know that there's a lot of discussion about expanding multidisciplinary models into general practice. From your perspective, why does this matter that the team is connected to the patient? And I would like you to expand a little bit about what GP-led multidisciplinary care looks like in general practice.
Yep. One of the things I'm very concerned about with this this increasing fragmentation, we've got every man and his dog wants to do a little piece here and there, not connected with the GP team. Now, I see that as a huge problem because at long term, it's going to result in a shared lack of responsibility, is the way I think about it. Historically speaking, GPs have been responsible for a specific patient population, specific cohort. And when you feel a sense of responsibility and you know what's going on with that group of patients, you can actually take responsibility for things like vaccination rates, for how the HbA1c is going on average in your patient population, a whole bunch of stuff. Whereas if we spread that out throughout the health system, who is driving the bus? And who is actually making sure that any little piece of data that could be important actually gets followed up on? And it then runs deeper than that. And I think you'll understand this, Ramya, that as we see more and more and more different providers, and there are some good things happening in the system, there are others that aren't so good. But if we have a pharmacist prescribing antibiotics for UTI, patient goes to an urgent care clinic for another piece of their care. They seek an online prescribing service to get a quick script and a medical certificate, and then they go to an emergency department for something else. All of those pieces of correspondence are coming back to the regular GP and adding an incredible burden. And anyone who knows the maths of systems of communication know that every single individual that's added to a team results in the number of pieces of correspondent connection increasing by the number of members in that team. And so it just becomes a hyperbolic curve of correspondence with no one really owning anything. So I think we really need to push back on that. I think it also goes to trust. Humans develop trust through a relationship, and relational care is where we're at our strongest, and it's where everything has been shown to make a difference in terms of population health outcomes, health economics. It's all about continuity of care, and that's why it does need to be under the one roof, in my opinion.
And I completely agree with you, Aaron. And I think as a practicing GP and a practice owner myself, some of the challenges that you and I see alongside our colleagues in our rooms is actually quite concerning for our patients and their outcomes. So now we're talking about an ideal model, and that's you're leading that team with your practice, and I want to understand a little bit more about what does it cost. This is an important conversation to have when we talk about funding, because often we know that general practice is, less than 5% of the federal budget in terms of the funding. And we've got to consider if we are at a point of cross-section in general practice with funding, health reform, better outcomes for patients, we actually have to invest more. And we've got to invest more with a purpose. So what does it cost a practice to provide good multidisciplinary care? Perhaps things that our patients may not be seeing, or maybe sometimes some of our own colleagues may not be recognising that if they're not a practice owner.
Look, I would say that for us, it is at the expense of short-term margin. I think there's no doubt that trying to provide this sort of care, we don't get remunerated for a whole bunch of stuff, around having a clinical advisory group. There's no extra funding to a practice to do that. For purely economics, having a GP in a room is much better than having an allied health specialist. But, and there's a big but here, I think the cattle style churn them through type medicine, where you don't have a full service general practice and a multidisciplinary team around the patient, short term it's probably economically better. But I think in the very long term, we actually start to lose relevance, because as I said, I think earlier, our role is management of continuity and complexity. And in today's medical environment, I don't think you can genuinely address that complexity without having a sufficient team around the patient. And I think there probably is a role for transactional type health services in the medical system. Access is important, and it shouldn't be that we ignore access, but our value is very much more in that continuity of care model. And anyone who's got a longer horizon, beyond that sort of 3 to 5 years that private equity typically looks at, if you're looking at 10, 20, 100 years into the future, the best thing you can do for a sustainable business is to have that great relationship with your local community, because you know you're embedded and you're part of the system. Whereas I think we'll see a race to the bottom of the transactional healthcare model and really reducing economics of that work.
Yeah, and I think I've reflected on this and spoken to colleagues regarding the funding structures. So how do you feel the current Medicare incentives or structures that are available for general practice is helping, and more importantly, why and where do they fall short?
So I think the practice incentive program and the workforce incentive program are a great seed of possibility here. But the reality is they haven't been indexed for many, many years, and we're seeing further defunding of the what is essentially some block funding to practices by that not having been properly indexed. I think that there are two elements to it. I think we need more incentive in our system to have sort of voluntary patient enrolment and funding of continuity. And the best model I can see of that internationally is what they do in France. At least they did many years ago when we were living there, where you can see any GP in the country just like you can in Australia. And it's essentially a free market system. But you have the ability to enrol with your regular GP, and you get a higher rebate when you attend that regular GP. And I think that is an absolutely fantastic mechanism to encourage patients and reward patients for attending the same practice or a specific GP because of the value it provides the healthcare system. And now that's not to the detriment of transactional services where people might want to go online. They might just pay fully out of pocket. They might need to go to a GP as a drop-in for some reason. But really, if we're going to spend our public purse dollars wisely, we should be actually incentivising continuity and paying for it and rewarding it, because it saves money for the public hospital system, it saves money for our country, and it results in better healthcare outcomes. And currently we don't really have a good mechanism to do that. There is some incentive, but it's often wrapped in red tape at the moment with My Medicare. And it's actually those incidental consultations over time that I think provide a lot more value just beyond the chronic disease management items. So I'd love to see the system go that way personally. And I think we need to think as well about governance payments. Clinical governance in complex teams is much more important than it was when we were single doctors working in single clinics. I think we need to fund that and reward good work in that space, and that could be managed somehow through accreditation. And I think the two roles that we've seen be incredibly valuable at Grow Life are having a pharmacist in general practice, from really encouraging quality use of medicines, and actually providing value from pharmacists being involved in the GP team. I think the community pharmacist prescribing issue is really not providing value to society, whereas pharmacists are incredibly valuable as part of the practice team, and the way that they act as governance over quality use of medicines. And I think a dietitian also, we found that very useful in our governance mechanism for looking at the non-pharmacological population health needs of our community and having a spokesperson role in that.
I think that's very helpful, because the pot of money, we need to be putting it into the right place at the right time. And the structures that you've discussed about are things that I discuss with my practice team. And when the margins are quite slim, we're considering what are our opportunities here. But I think you've raised some really great points for us to sort of ponder and think through. Now, on that note, at a grassroots level, what would make the biggest difference for practices trying to build their strongest teams? What would be your advice?
I think talking to your PHN and seeing if they've got anything that they can help fund to catalyse change in your practice, I think is a really great starting point. That's certainly helped us quite a lot. I think we need more funding for population health and quality improvement. Looking at your practice data and actively intervening, I think, is a super valuable thing for society. And whilst we do have the QI PIP, I don't think it's enough to really make a difference. And I think that those funding mechanisms are woefully inadequate. And I think at the moment we're probably seeing a little bit of a trend or predilection from the Department of Health and Ageing to want to sort of block fund or capitate general practice. And we've seen that simply does not work. That doesn't mean I object to some increase in the block funding towards general practice, as a small percentage. But what we must resist is this idea that you can just pay a single lump sum, because what it does, it removes any incentive for practices to actually do that access and volume work. And we have to be very careful about how we get the balance right. And what I absolutely do not want to see is this trend that we are seeing towards a 2-tier system or even a 3-tier system. That is the opposite as what I see as a country that has health equity at heart and of a fair go, like we expect in Australia. And I think we should be saying, well, actually the funding needs to follow the patient and their need and not be directed towards a particular type of clinic. I think that's the opposite of what most Australians believe in.
Yeah, well said, Aaron. I couldn't have said it any better. So, very well said. Now, as we're coming towards the end of our session for this podcast, as we think about the future of general practice, what should we be advocating for when it comes to multidisciplinary teams?
I was involved in a clinical trial called ACTMed, where they embedded pharmacists in general practice to look at how that changed the quality markers for use of medicines in the practice. And whilst it took some time and there was a lot of change required, so we're talking 6 to 12 months before change really starts to bite and make a difference, the ACTMed trial was very instructive in that respect. And I think it demonstrated, to my mind, the value of embedding a pharmacist in general practice and how it can actually mean that the team coalesces around solving some particular problems and that we can get better value for the healthcare dollar. I would really like to see that mechanism funded in general practice properly. And at the moment, the whip really doesn't sufficiently fund that. So I think that is number one in terms of ask. I think I said before, this incessant drive towards cashing out fee-for-service revenue and moving to capitation, it's the opposite of what's good. I think anyone with any basic knowledge of economics kind of understands that actually markets work better, but they have to be very well-regulated markets. And that's what we need in healthcare. So we need really a blended system that funds continuity. Like I said, we want to make sure that there's an incentive for patients to see their regular GP or the regular GP clinic. And we should be really pretty hard on that. I think we've got sophisticated enough mechanisms now that governments know through various mechanisms how much need patients have, and software and its capability is getting much more sophisticated. So we should be looking towards attendance-based loadings based on complexity. And that's going to take a while. I don't think we can jump straight there, but that's where I think we should be looking towards, to say if you've got a patient who has been long-term unemployed, is on a disability pension, has diabetes and significant disadvantage, they should be funded more to see their regular GP so that they get good care, which is fair, and so that we save money for the public healthcare system. And that should follow that patient. And patients otherwise, children, I think we should be making sure that children are extremely well funded, because I believe that the healthcare a child receives should not be dependent upon their parents' income. And I'm quite sad to say that is now the case in Australia, because it is very dependent. Whereas once upon a time, bulk billing rates were near universal for children. And I think it's quite a tragedy that we haven't allowed the mechanism to fund children getting good care to keep up with the economic reality of general practice.
Yeah, that's very well said. And we're talking about health inequity as well in relation to that. So now, if you had one message for government about multidisciplinary teams in general practice, what would it be?
That they need to understand we need to work as a team, that it needs to be under one roof, and that government needs to step in to make sure that getting access to that allied healthcare doesn't need to be free, but it certainly must be made cheaper when a patient goes to their regular GP and gets that care as part of their general practice team, so that patients are incentivised to stay within that team because it results in better outcomes.
This is exactly the conversation that we need to be having, Aaron, and I'm very grateful for you taking time today and speaking about your experience, your vision, and where we need to be heading with general practice and multidisciplinary care. The future that I do see is not GP versus the team or GP versus anyone else. The future is GP-led teams. However, it needs to be properly funded, valued appropriately, locally designed, as we have just heard, and built around patients and communities where the need is there the most, and understanding that, and not necessarily a blanket sort of opinion or a note to just throw it around. And I think it's really important for us to come out of political cycles as well in terms of our policies. Our policies need to be driven economically, but also something that's going to improve the economic productivity of our nation, support our communities, and not, sort of band-aid solutions for a political cycle either. So I think it's been really valuable, Aaron. It's really important to hear from leaders like yourself, leading a wonderful team and having innovative practices across the country. And it's just been such a privilege to have you on board today with GP Insights. So thank you again for your time, and look forward to catching up with you very soon for the next one.
Thanks very much for the invitation, Ramya, and thanks very much for your leadership in the college.
Thank you.